I mentioned to you earlier I had the opportunity to spend 2 weeks in Azerbaijan back in November, and one of the first cases they showed me in the neonatal intensive care unit there was a case of Kernicterus. And I will have to admit to you, I have never seen a case of neonatal Kernicterus before, okay? It's something we try to prevent in the United States, but it struck me that, this is still something that we are constantly, as neonatologists, as pediatric care providers, we have to try to prevent this from happening. So I'm just curious, who of you in the audience have seen a case of neonatal Kernicterus? Okay, about what I thought, fair number of hands raised. And so I spent some time with the colleagues there going through some of the algorithms and tools that we have to treat this, talking about some of the therapies that we do use to try to prevent Kernicterus from happening. And so I've got a case. It's not a 100% true case. It's an amalgam of several different cases, both in my neonatal intensive care unit in Nashville and based on what I saw in Azerbaijan. And we're going to work through this together, and I'm going to show you some of these things that we use. So hopefully we can prevent this from happening. But one of the babies that I did see there was a 35-week infant who was born in a small rural hospital. And in their healthcare system, if these babies are born in these rural hospitals, it can take somewhere between 4 to 6 hours before the babies get into Baku, before they can undergo therapy. So at this rural hospital, they noticed that the baby was jaundiced in the first 24 hours of life at the level of 259 micromoles, and was transferred to Baku for a further evaluation and care. And you, as the astute pediatrician, know, of course, 60 to 80% of all newborns are going to develop jaundice at some point. And our job is to figure out if this is physiologic jaundice or if this is pathologic jaundice. So physiologic jaundice, first off, you notice it between 24 to 72 hours of life. These babies are typically going to have a maximum level that 4th to 5th day for that term infant, around day 7 for the preterm infant. It's usually going to be mild, about 257, and it'll be clinically undetectable at the end of the 2nd week of life. So once our baby gets to Baku, the level's 300, okay? At this point, we are dealing with a medical emergency. This is pathologic jaundice, and so we have to treat this. Even though the baby looks nice and cute, this is a medical emergency. And so us as pediatricians, we as pediatricians need to realize that this is something that can be severely detrimental to this baby. At this level, we are still in the largely reversible stage of bilirubin neurotoxicity. And so there's something called a bind scoring system to help us determine if there's acute bilirubin encephalopathy or not. And if the baby is sleepy but arousable, has mild hypotonia, poor feeding, or a high-pitched cry, they get a bind score of +1. Bind score of +2 is a baby with lethargy, a poor suck, irritable or jittery baby, a baby with either alternating hypo or hypertonia, a baby who exhibits bicycling. This is pretty severe nuchal rigidity, but they can begin to show nuchal rigidity and truncal arching and will have a shrill cry. A bind score of 3 are those babies that are unable to feed. They have apnea, seizures possibly, coma, retro or epistatonus, severe hypotonia, and may have an inconsolable, weak, or absent cry. And those babies have a bind score of +3. And you can use this scoring system to give you an idea of what these babies' outcomes may be. If you've scored the baby very early on, when they present with a score of 7 to 9, it can give you an idea if they're going to have chronic bilirubin encephalopathy or if they may fail their hearing test and have chronic hearing problems. So this bind scoring system can give us some early information into outcomes and if these babies are going to go on to develop this chronic bilirubin encephalopathy, because this is what we are trying to prevent. These hyper intense basal ganglia lesions as seen on our scans, and if the baby passes away, this bilirubin deposition in the basal ganglia area. So for those of you who have not seen somebody who has survived a case of kernicterus and has chronic bilirubin encephalopathy, this is what it looks like. These children may have muscle tone abnormalities. They may have neurobehavioral manifestations, things like ADHD as they develop. They're going to have some speech and language abnormalities. And they're going to have an array of central processing abnormalities as well, such as vision and hearing problems. It is estimated that 1 in 40,000 children with jaundice, if left untreated, will develop kernicterus. And the thing is, this is a totally preventable disease, a totally preventable phenomenon. And this is something that we need to try to make sure we're picking up on and treating. As you can see, Jordan, as well as my friends in Baku, are in this area that there's a huge unmet need for phototherapy because of the risk factors in the patient population here, and your still advancing healthcare system. Again, this is something that falls under the Millennium Development Goals to reduce child mortality. If we can treat these babies who develop severe hyperbilirubinemia appropriately, we're going to prevent a significant number of deaths and cases of kernicterus, as well as preventing these children that go on that need long-term health care needs from our healthcare systems. So what does not work? Relying on the visual assessment alone does not work. It's something that's passed on pediatricians and even in training, and something that we sometimes think we can do a good job of, but this does not work. Withholding breast milk intake unless indicated is also not effective. Using our clinical judgment to determine risk is something that doesn't work too, especially when we have some very good tools I'm going to talk to you about in just a second. And various chemopreventative agents have not yet been proven to be effective either. The mesoporphyrins is something that has been looked at for many, many years now, and it would be wonderful if something like this works, but unfortunately they have some unusual side effects, such as these rashes. And if our pediatric dermatologist was here, I'm sure she could tell us all about these. I don't know how influenced you are by some of the Iranian medical world, but in Iran they use clofibrate to try to treat jaundice. I would caution you on that. That was discontinued, at least in the U.S. market, in 2002 due to adverse effects, and I would caution you about using that in our patient population as well. So let's go back to our case with this baby that has a jaundice level, a bilirubin level of 300, and try to work through this. First off, we have to look at some of the causes for hyperbilirubinemia. And I'm not going to belabor this point because I know that you are aware of all these different things and know how to work through this. I just want to place this up there very briefly so you can know we're thinking through this, trying to make our diagnosis. And this is also a nice little flow chart you may want to get a picture of to use later, because we're going to get some tests here to work us through each one of these limbs to see if we can come up with a diagnosis in our case. And so we got a reticulocyte count, which was 18%. We also obtained or found out that the maternal blood type was O positive, the baby's blood type was A positive, and the Coombs test was also positive. So we have a hemolytic disease of the newborn, or ABO incompatibility in this case. And you may think at this point, this is what I need to do next, is an exchange transfusion. And you may be right, but let's think about this before we jump to it, because I want you to think of the exchange transfusion as really a crash landing. If you remember from the simulation talk I did just a couple of hours ago, we don't want to crash. Okay, we want to think through things and do things as quickly and as carefully as possible and have all those boxes built in our brain so we can work through our our best choices and best options. So let's look at an evidence-based approach to rescuing this baby from Kernicterus. Have you seen Billy Tool before? Do you use this regularly? Okay, Billy Tool is a website from the American Academy of Pediatrics. It's just billytool.org. It's a great resource. I'm going to show you another one here in just a second from our friends in Europe. But with the Billy Tool, you can plug in the day of the baby's birth, an hour of the baby's birth, when you obtain the blood sample, and what your bilirubin level was, whether it's in the milligrams per deciliter, which is the U.S. standard, or in our case, using micromoles per liter, a level of 300. And once you plug that in and press the submit button, it'll give you some recommendations. It'll ask you to stratify the baby and what the risk is. It's a low-risk baby, taking into some effects here, or some risk factors here. Some medium-risk baby or high-risk baby. And then it'll tell you if you need to do phototherapy and when you need to recheck the bilirubin level too, okay? Specifically, what we want to look at next are some of these nomograms right here. This first nomogram is referred to as the Butani nomogram, published in 1999, and gives us an idea of if we are going to need to intervene in this patient. And you can see we are already in the high risk zone. This baby is at quite a high risk that we are going to need to intervene and do something. So already you know you need to be kept on your toes and alert. If you look at the phototherapy nomogram, again, we need to be starting phototherapy aggressively in this baby while we're trying to figure out if we need to do anything else. And that brings us to the exchange transfusion and the exchange nomogram. We're right there on the line. Of course, if we do an exchange transfusion, we're committing this baby to a very long procedure. We're committing the baby to multiple other risks of exchanging the entire blood volume and sticking another human being's blood volume into this baby. So we want to try to prevent this, use this for a crash landing if possible. So keep calm, because there's an app you can use too. And I like this one actually a lot better, especially if you use the European lab standard. You can go to iTunes or App Store, download this for free, the Billy app tool, which is put out by our friends in England based on their data and literature. It's again very similar to the US data. I just think it's plain easier to use because it's right there on your phone. You put in the baby's gestational age, the date of birth, time of birth, the current bilirubin level. If there was a previous level on this baby and the times, you hit the go button and it tells you what you need to do, okay? Just as we've been talking about so far, start getting things ready because you may need to do an exchange transfusion. Start your multiple phototherapy at this time. And then it's going to give us some other recommendations too we're going to talk about in just a second. All right, it gives you a nice handy little chart and graph. And let's go to our phototherapy. How many of you have lights like this in your neonatal intensive care unit using the fluorescent lights? One? Anybody else? How many are using LED lights? Okay, vast majority of you. That's good. When I was in Baku, most of the units I was in are still using these fluorescent lamps. These are hard to maintain. You have to keep track of how many hours your lamps have on them. They can become ineffective very quickly. Frequently, you will have bulbs burnt out, so the baby's not getting as effective phototherapy. You have to make sure that you're measuring the distance appropriately too when you're using these. And you have to have a device like this so you can keep track of the irradiance. Okay, so there is another company that is making a device that is LED lights. In the United States, for us to buy a bank of LED lights, it's like $6,500. They're incredibly expensive. This company in India that is trying to prevent kernicterus, just like we are talking about, are selling these for $400. They're very effective. I actually, when I was looking at this company's website, I saw that these are in Jordan. Is anybody using this brand in Jordan? Okay, somebody is, because they had you marked as a country that is a user. So it's a great quality light. Certainly keep that information available, something you may need to invest in for your practice or your neonatal intensive care unit. One of the other things you can do, if you need to make sure you're optimizing your phototherapy and getting as much surface area of the baby as possible, is you can use something like aluminum foil or white cardboard to reflect the dispersed phototherapy light and actually increase the irradiance to the baby to make sure they're getting more. So in this situation here, we have 2 lights on top of this baby with actually a third light, a billy blanket, underneath the baby to make sure we're getting all sides and all exposed areas. Early on in this baby's course, none of this side bedding and diapers and stuff like that was on this baby, because we were trying to prevent an exchange transfusion as well. So let's go back to our recommendations. Something else is mentioned here, okay? Using intravenous immunoglobulin, okay? And that is something that can be effective, although I will admit there is some skeptics about this, but we've been using it for well over a decade regularly in the United States with a lot of effectivity in preventing exchange transfusions. But using intravenous immunoglobulin with hemolytic disease of the newborn. And when you look at some of the meta-analysis, sure enough, there is a positive effect to help you prevent the exchange transfusion. And what seems to happen is the IVIG occupies this receptor site to compete with the sensitized neonatal erythrocyte and then actually prevent the hemolysis from occurring. Very small number needed to treat to prevent 1 exchange transfusion, 2.7, which is great. Certainly something we like to see. So you can use, while you are prepping or considering doing the exchange transfusion, we will begin with a single dose of IVIG, anywhere between 500 milligrams up to 1 gram per kilogram, and may repeat this dose. The baby I showed you earlier, the picture with the aluminum foil around it, that baby got a second dose of IVIG at about 48 hours of life, and we were able to prevent the exchange transfusion. The key to doing this is administering this as soon as the diagnosis of the hemolytic anemia is made, because the sooner you get it on board, the sooner you can prevent those red blood cells from undergoing hemolysis, and the less rapid the bilirubin level will rise. There can be an increased incidence of late anemia, but I would much rather deal with this than having to do a double volume exchange transfusion. All right, so we want to prevent, not just cure. Prevention is always better than the cure. So first off, we need to use ROGAM. We need to get our obstetrician to make sure they're testing, making sure that they are treating mothers appropriately. We as pediatricians also need to educate our families. And when I was reviewing the literature here specifically for Jordan, there are some cultural things here, as in the United States and all cultures around the world, that we have to make sure we're educating our mothers correctly about. Salting is apparently something, salting infants is apparently something that's done in the Arabic world. Is that right? At least I found some articles about it. And there was some associated Kernicterus that had occurred with the severe hypernatremia that sometimes occurs with salting. So make sure we're warning our mothers about some of our cultural practices and making sure we're following those babies carefully. One of the other things that we're doing now is being able to measure bilirubin without actually checking blood. Transcutaneous bilirubin meters are being used much more frequently in the United States now. These devices are actually very accurate. Unfortunately, they're about $7,000 per unit, but it does help us save sticks, and it does give us a very accurate and very quick reading. There are multiple articles to support the accuracy. Even down to about 28, 29 weeks of gestational age, we will regularly use these devices on as at least a screening tool before we will confirm with the blood test if needed. But there's also an app to measure bilirubin without blood coming soon, most likely. This was published just a couple of months ago in Pediatrics. There's a smartphone app that is undergoing, it's actually already been developed, but it's undergoing approval right now. In my understanding with personal communication with Dr. Taylor, who's a senior author on this paper, this is going to be amazing, and I think this is going to be very helpful for all pediatricians around the world, as well as our patients, if we can teach them how to use it appropriately. But what you do with this little app in your iPhone is place a nice little color square on the baby, and they've tested this in multiple different racial and ethnic groups, and it's just as accurate as the transcutaneous bilirubin meter. Then you take a picture of the smiling baby with the little rainbow colored sheet on his belly, and you zap it up into the net somewhere, and it contacts a server and sends you a number and tells you what the baby's bilirubin level is. So a wonderful screening tool that you're going to be able to use in your office, or possibly even send it home with your parents to check their baby. And they concluded in this report that BiliCam could be part of a system of care that could significantly reduce the morbidity and mortality related to hyperbilirubinemia. And of course, that's what we're trying to do, because we're trying to prevent kernicterus. And as I wrap this up, I've got to share this with you. So this is the firstborn child of one of my neonatal nurse practitioners. Okay, she was not a neonatal nurse practitioner yet when she had her first child. And her baby's bilirubin level got up to 544. She could have used that app, I think. Now, just out of curiosity, what do you think happened to this baby? How do you think she is? So you remember I showed you this picture earlier. I mean, this is almost off the chart for irreversible brain damage. So this is her today. She's 16, 17 years old. She took her college entrance exams. This is her 8th and 9th grade scores. She's supposed to be taking the real ones to enter college here in, I think, next month. So somehow this girl has some amazing genetics that allowed her to avoid kernicterus. Don't try to do this at home, okay? This is my teaching point. Do not do this at home. Don't take this chance with your patient. Somehow, inshallah, she was blessed. All right, so our conclusion. We've got to have structural, maternal, and child health care programs. I'm sorry, unfortunately, that didn't turn out, but this is a whole severe hyperbilirubinemia toolkit, prevention toolkit that's available on the internet from one of the perinatal qualitative care committees in the United States. As pediatricians, we have to be vigilant. We have to teach our parents vigilance, that this can be a problem. This is something we can prevent. There are lots of easily available tools that can help us make the best evidence-based decisions possible. And we have to use the resources we have in the best way possible. And if you can afford to develop your resources further, please try to do that. Continue to watch for some of these new technologies and treatments that are coming and adapt those into your practice. I certainly think this BiliCam is going to be a wonderful tool with this little smartphone app. That is it. Thank you so much.